Hello and welcome to the I Rehab podcast. My name's Nick Kane. Thanks for tuning in again. Excited about our guest today, Kevin Cronin. Kevin is the first radiographer we've had on our podcast. So looking to tap into his knowledge and skill set and how he uses, ultrasound for both diagnostics and monitoring injury throughout the rehabilitation process. And we also just explore a little bit of his past research around muscle architecture. Now, I first took some interest in what Kevin was doing with his work when I was in Ireland and did a masterclass with Eamon Delahunt, who was his supervisor at the time. And that was when Kevin was exploring the extended views with the hamstring architecture and the fascicle length, which I found interesting. And then furthermore, more recently, having chatted with the likes of Fergal Kieran and talking to, some of that monitoring space using ultrasound for hamstring injuries, but also for diagnostics in line with what MRI can provide. So hence reached out to Kevin to try to get his thoughts and views, and I knew he had a bit of a sub-classification when it comes to T Junction injuries, so I was certainly interested to hear that off the back of chats with Ernest Schilders and Fergal Kieran. So great to have him on board. I hope you enjoy this one with Kevin. But as always, at the start of the podcast, I like to keep you updated on our events and what's happening, and I try to keep it really short and sharp. But we do have Fast Track the Injured Runner coming to Boston in mid-October. So that's going to cover hamstring injuries to calf, Achilles, patellofemoral pain, bone stress, footwear and nutrition for the running population. So super excited about that at an amazing venue. The track in New Balance is brand new, elite facility. So we can't wait to get there. We have Michael Giacomis, injury consultant, who's doing 2 courses in Melbourne. They're 1.5 day courses. One in Melbourne and one in Perth early December on the thigh, so rec fem and hamstring injuries. And we are about to release our annual conference coming to Melbourne in early February on a topic to be announced, but I think people will be happy and looking forward to engaging with all our followers and members at these events. All right, that is enough from me with our intro, and let's get into this chat with Kevin. Kevin, welcome to the I Rehab podcast, mate.
Thanks for having me, Nick.
Mate, looking forward to chatting with you. You're our first radiographer to have on the podcast ever. So I'm excited to go down a little bit of a different path with your experience and background. Now, you've obviously been involved in a number of publications, but please fill us in a little bit about your role now and what you've been doing in the past, and I guess where this interest comes from when we're talking around the hamstrings.
Yeah, so listen, thanks so much, Nick, for having me. I suppose just to take it back as to who I am, I graduated from University College Dublin, Ireland, with a radiography degree in 2013. And from there, I worked in a nearby university teaching hospital as a basic grade radiographer. And then I returned approximately 2 years later to undertake a master's in general ultrasound. And during this time, I was working still in the university teaching hospital, mentoring students throughout their clinical placement. In 2017, I took on a lecturing post in the Diagnostic Imaging section in the School of Medicine, which sees me where I am to date. My current role is I'm a lecturer in the Diagnostic Imaging section in the School of Medicine, and I'm also the program director for the Master's Ultrasound. And outside of my academic role in the School of Medicine, I work 1 day a week clinically still as a sonographer. And I was fortunate enough last year in 2024 to set up my own private ultrasound clinic in my hometown of Limerick with my colleague Lee Tweedle, who's a fantastic sonographer. He's an Australian. He's from an area about 3 hours north of Melbourne, from an area called Mycia, population 8, near Bort, I think it's called, in central Victoria. That sees me working clinically 1 day a week. So that's the background to who I am. And then I suppose my clinical interest in hamstrings really took off from speaking to a very good friend of mine by the name of Thomas Divley. Thomas is a fantastic physiotherapist who together with his fiancée Fiona. They own their own clinic in Clarenbridge in County Galway, west coast of Ireland. And at that time, I was always thinking about undertaking a PhD or getting involved in some research with my academic role in the School of Medicine. My boss encouraged me to think about undertaking a PhD, Professor Louise Rainsford, and it was Thomas who, I suppose, really taught me to maybe start linking in with guys like Professor Eamon Delahunt, who I suppose you know quite well. Professor Eamon Delahunt is published extensively in the field of sports medicine. He's contributed so much to it. He had an extremely strong, I suppose, career in supervising PhD students. I'm not too sure how many PhD students he's supervised to date. It's definitely exceeds over 10, close to 15 PhD students as a primary supervisor. So Thomas encouraged me to speak to Professor Eamon Delahunt, and this was in the early summer of 2018. So I got in touch with Eamon and we set up a meeting, and we fished out a couple of research projects. And it was really this topic that he mentioned on hamstrings and architecture. And I'll have to put my hand up. I really didn't know anything about architecture at the time. And based on my clinical skills, it maybe wouldn't be something we'd be looking at in the clinical environment. But yeah, during that time as well, Eamon had a PhD student by the name of Fergal Kieran, and Fergal was a student of Eamon's who was conducting research in Leinster Rugby. Hamstrings were a research priority in Leinster Rugby because they were sustaining a lot of hamstring injuries, and Fergal was conducting research in this area. Eamon spoke to Fergal about the possibility of using ultrasound to assess architecture. And Fergal and Eamon had discussions with Gareth Farrell, who was and still is the head physiotherapist, head of medicine in Leinster Rugby. And from there, really, we got the green light to conduct some research on professional rugby union players assessing architecture. And at that time, I just started reading a lot of the work conducted by Dr. Ryan Timmins. He had published extensively in this area together with David Opar and Jack Hickey as well. So I really started reading a lot around that time, and identified maybe some of the technical improvements that I suppose before we would ever put an ultrasound probe on an athlete, how maybe from my side, from my research and my PhD, that we could really improve the technical aspects of the ultrasound acquisition period.
Nice. All right. So it's a nice little background, but you're also, before we jump into talk around architecture and then probably some diagnostics when it comes to ultrasound in today's chat, you're also a father, a young kid, and you're almost 1 year old, 1 year old, and also still having a run around with the hurling, correct?
Yeah. So we have my wife Margaret, we have a 1 year old little girl, Fia. So it's an Irish name. It means little wolf when translated. So yeah, Fia is fantastic. She's going to be 1 in 2 weeks' time. So we have we've her christening this weekend, but that has been an absolutely fantastic last year for us. She brings us so much joy and happiness. And I have a keen interest in a sport called hurling in Ireland, and probably coming to the very end of it, but I play with my local team now where I live. It's called Éire Óg, Greystones, County Wicklow. So Greystones is this beautiful seaside town, approximately 15 kilometres south of Dublin. So I play with my local team there, and it's been a fantastic way to integrate into the community.
Beautiful. Oh, nice, mate. Nice to probably get a little bit of an idea on who you are and where you've come from. And before we can, I guess, delve in, and we're only going to probably spend 20% of the podcast chat on architecture. But I guess, having worked in Australia for a number of years, some of the work pioneered by Timmins and the crew you mentioned there was pretty foundational and used quite a bit. And I guess from there we hear a lot around in the clinical world around, trying to achieve improved architecture or fascicle length. And you obviously went further with a little bit of study, but I guess before we jump into that, can you just tell us what is muscle architecture and increased fascicles?
Yeah. So muscle architecture, it's the geometric distribution or the arrangement of muscle fascicles or fibers within skeletal muscle. And muscle architecture essentially determines a muscle's mechanical function in skeletal muscle. And it influences its maximal force output and contractile velocity. So the angle of trajectory of a muscle fascicle or fiber between these little structures within the skeletal muscle called superficial aponeurosis and its insertion into a deep aponeurosis or central aponeurosis or central intramuscular tendon, that's referred to as pennation angle. And large pennation angles associate themselves with shorter fascicles, which reduce the contractile velocity and muscle excursion and the range of muscle. Whereas in contrast, smaller pennation angles themselves associate themselves with longer muscle fascicles, which decrease the cross-sectional area and maximal force output of the muscle. So it's assumed for muscle architecture during fast eccentric activity. So your typical mechanism associated with hamstring strain injuries, that the muscle tendon unit itself undergoes active lengthening. And during this type of contraction, long muscle fascicles compared to the shorter muscle fascicles will exhibit less strain per sarcomere in series. Remember, a sarcomere is the functional unit of skeletal muscle. Now, there's limited evidence to exist to characterize the effect of hamstring muscle architecture on the architectural characteristics of strain, but one prospective study conducted identified that previously strained hamstring muscle architecture possess shorter fascicles in comparison to the uninjured fascicle or uninjured muscle itself. So shorter muscle fascicles contain less sarcomeres in series, which will result in a reduced maximal shortened velocity, which could increase the risk of re-injury. So the ability to accurately quantify the architectural characteristics of hamstring muscles, it may assist clinicians in the management of athletes with acute or recurrent hamstring strain injuries. So it's quite controversial, but my take on it's extremely operator dependent, and unless we have an accurate technique, are we really getting accurate measurements of our hamstring muscle architecture? So, in summary, Nick, fascicle length is the distribution of fascicles within skeletal muscle, and the majority of the conducted research would state that athletes that exhibit shorter fascicles or have shorter fascicles are at a higher risk of sustaining a hamstring strain injury. However, my take on it is it's an extremely operator dependent process, and at the ultrasound acquisition period, we really need to get it right.
Yeah, I guess that's probably where we sort of come to when we're talking around people saying it is important, but I guess how it's so hard to get good access to that and that's accurate measurements. Your research more looked at the wider view, I believe, or the extended view. Tell us what this gives us more from an accuracy point of view compared to maybe what the earlier research had done. And also then, if I am someone working in clinic space or sports, how do I get good accurate measurement? Is there only really selected people around who can do it for me?
Yeah, look, most of the published research to date used a ultrasound field of view to measure the architectural characteristics. Essentially, it was a limited field of view. Essentially, the field of view that the ultrasound transducer had was much shorter than the fascicles under interrogation. And what that meant is that they needed to use these extrapolation methods or trigonometric equations to estimate remaining fascicle lengths themselves. And these extrapolation methods themselves are predominantly use linear approximations based upon muscle thickness and pronation angle, and they don't really account for fascial curvature and, in my opinion, are prone to error. So the literature would state that, using linear extrapolation methods on visible fibers that you see on your ultrasound image with a field of view of 5 centimeters that you have with your conventional or normal ultrasound transducer itself overestimates a biceps femoris fascial length. And this has been, I suppose, somewhat identified in recent research from different techniques such as the extended field of view, that the linear extrapolation methods used to estimate remaining fascial length or overall biceps femoris fascial length itself overestimates fascial length by 2 centimeters, which is quite large. And I think that's why you see such higher lengthy fascial lengths with these previous studies, or with studies using 4 or 5 centimeter field of view ultrasound transducer themselves. If you look at some of the research historically, some of the reported fascial lengths were up around 10, 11 centimeters themselves. If you look at some of the recent extended field of view figures, they're down around 8, 9 centimeters. And with our technique, we use a technique called wide field of view. And that essentially is like the limited field of view. However, we use an ultrasound transducer that has a field of view that's 10 centimeters in field of view. So the previous research would be using field of views of between 4.7, 5, 6 centimeters, or ultrasound camera, probe, transducer, whatever you want to call it, has a field of view that's 10 centimeters. So it's different to extended field of view, which I'm certainly not sold on, and I have my take on that, because we definitely tried that in practice and it didn't work for us. So that meant that we needed to go off and find a ultrasound transducer or probe that permitted full fascial visibility, that allowed us to take static images of the architecture. We did play with extended field of view or panoramic imaging. It's got a different terminology between times, but it's extremely difficult to do. It means that you actually have to dynamically shift the ultrasound transducer across the posterior thigh, and any misalignment of the ultrasound transducer from the field of plane of the architecture, particularly in a muscle like the biceps femoris that has a bipinnate muscle, meaning the architecture actually goes off in two directions. So any misalignment of the ultrasound beam from a fascicle itself renders the image not useful. You get a fuzzy image essentially, and you have to start back at step one again. So to start using extended field of view, we felt that it definitely wasn't feasible, particularly if you're screening large cohorts of athletes, depending on the type of sport you're involved. If it's football, soccer, you're talking maybe a squad of 30 players, or if you're talking GAA in Ireland, hurling, football, or even rugby, you're talking 30, 40 athletes within one squad, and time is tight and you need to get accurate images, so it definitely wasn't feasible. And also extended field of view, it's not available on all ultrasound systems itself. So we felt that extended field of view and the limited field of view, it wasn't the route to getting accurate ultrasound images of architecture for the biceps femoris long head muscle. And that's where we used a wide field of view technique that permitted full fascial visibility.
Yeah. Okay. So breaking it down, would you say obviously it's sort of deemed an important aspect when it comes to injury risk mitigation for hamstring injuries, but maybe where we're still evolving in the space to, one, have really good accurate measurements that we can really confidently rely on, and I guess the secondary issue is access to someone who can do that for us on a regular basis. Is there one other thing on architecture, I guess, before we move on? There's one argument around, being a static measure versus for a dynamic muscle. Do you have a view on that? And has there been some developments in that space that you're aware of?
Yeah, there has. I mean, USANO ProFix is definitely doing a lot of work where they're looking at the dynamic evaluation of the muscle, and trying to assess the architecture at that time. I think it's good at looking at it in real time, but we can't really measure it retrospectively. We can't measure architecture or tendon planes when there's movement. It's extremely difficult. So that's why the majority of the work is conducted static. And not only at the acquisition period, we had to make improvements post analysis. The majority of these, I suppose, acquisition periods assess architecture with imaging tools, measuring curved fascicles with straight lines. But we had to develop an algorithm that accounted for fascicle curvature, and that's been proven. If you measure something that's curved, whether it exhibits a concave or convex curvature itself with a straight line, you're either going to overestimate or underestimate a fascicle length itself. So a fantastic colleague of mine, and he was a supervisor in my research, Dr. Sean Kernan. He was in particular instrumental in developing a imaged algorithm that allowed me to quantify my architecture precisely and accurately. And we published that paper as well. The title of that paper is Semi-Automated Tracing Algorithm. So it's quite tedious because it's semi-automated. You have to trace particular points of the fascicle on the image with a series of clicks, and it accounts for fascicle curvature, intramuscular curvature, gives us a series of pennation angle measurements, but it's the most precise method, my take on it. Instead of using your traditional ImageJ tools to measure curved fascicles with straight line tools. So that's where we really went at it at the beginning. We really wanted to improve the technical aspects of acquisition in terms of that wide field of view, but also post acquisition at the analysis period. We wanted to account for all those curvatures to really kind of give us that true, perhaps maybe fascicle length measurement itself. And the majority of our fascicle lengths that we're seeing to date are much shorter than the previously reported fascicle lengths. So we're seeing ranges from maybe anywhere between 6 to 8 centimeters. And I think that kind of sits in somewhat near enough to the extended field of view measurements themselves.
Yep. Okay, so it sounds like we've got still some, I guess, work to move through from where we as a clinician can, really rely on it and call on that as a, injury risk mitigation tool, but it's still obviously a key foundation. Probably leaves a few questions unanswered for us, but we are going to move on and talk through, I guess, an area of diagnostics when it comes to ultrasound, and this has been seems to have been something that's really come a bit more prevalent in recent years. So I guess to start off with, I mean, you were the lead author in a 2024 paper for BJSM, which looked at dynamic ultrasound for improved diagnostics to assess the healing of the T Junction injury. We chatted about this a little bit with Fergal in another podcast and Ernest Childers in a recent podcast as well. So, tell us a little bit, first of all, your view on this from a diagnostic point of view, and then we'll sort of move through the dynamic and T Junction aspects.
Yeah. I suppose with T junctions, imaging is frequently used to confirm and to assess the extent of an injury, which then can allow the clinicians to develop a plan to either rehabilitate the athlete back to a return to play, or maybe refer the athlete, depending on the type of injury, for a surgical opinion itself. In my opinion, in relation to T junctions itself, MRI in this instance is incorrectly deemed the gold standard imaging modality to diagnose suspected T junction injuries. I believe ultrasound should be the first line imaging modality to diagnose a suspected T junction injury. And I have a number of thoughts on that, but I believe MRI does not fully capture the complexity of the T Junction location. And as Dr. Fergal Kieran has alluded to this point before, the British athletics muscle injury classification is MRI based, and it doesn't really explicitly address the connective tissue components of the T junction, in my opinion. So I think my opinion, the utility of MRI for suspected T junction injuries remains uncertain, and I believe ultrasound answers most, if not all, of these questions. Our paper was just a short case study, but in relation to ultrasound and T junctions, I firstly ultrasound has a higher spatial resolution than MRI. Spatial resolution is a system's ability to distinguish between two nearby objects as separate, distinct entities on an image. And this ability is crucial for accurate diagnosis and locating these microstructures within the image region. So one connective tissue component of the T junction is its very superficial area, and we refer to this as the myotendinous component of the T junction. And ultrasound really gives us excellent visualization of this area. The T junction at this component, the myotendinous superficial component itself, depending on the athlete and BMI, and that sits essentially just maybe 1 to 1.5 centimeters deep. And ultrasound allows, with its penetration resolution, the ability to accurately, precisely, with great detail, assess this area quite well. And I suppose with the recent advancements of ultrasound technology over the last 5 to 10 years, the resolution itself has improved, and the deeper component of the T junction, that often referred to in the literature as the zipper component of the T junction itself, we refer to that in our paper as the myoaponeurotic component itself. Well, the newer ultrasound application systems and the scanners, it allows us to assess this area with great detail itself. So what I'm trying to say is the spatial resolution of ultrasound is much better than MRI at this area, because the T junction is so superficial. It allows us to look at all these areas really well and to give great clarity to the T junction on imaging. And then secondly, we mentioned in our paper the connective tissue components of the T junction. In other words, they're distinct anatomical components of the T junction that we see quite well, but are important to report if there's any obvious defect at these areas itself. So you can imagine if you have a T junction, and if you place your ultrasound transducer in transverse orientation or cross-sectional area itself, the horizontal component of that T junction itself we refer to as the myotendinous component, and the deep component we refer to, or the leg or the zipper, we refer to that as the myoaponeurotic component. And that's extremely important to visualize, because my take on it is that if there's a defect to the myotendinous component, that's a worse prognosis than a defect to the myoaponeurotic component, which has a better prognosis for the athlete. I suppose that's really just the structural makeup of those particular areas themselves. The myotendinous component, it's composed of a flexible cord of fibrous collagen tissue, and it's mostly composed of dense structure collagen, essentially, in comparison to the aponeurotic component, which is this thin sheet-like elastic structure that covers the muscle and portion itself, and it's delicate, and it mostly contains fibroblasts rather than collagen itself. So my take is, if there's a defect to the myotendinous component, it's a worse prognosis than a defect to the myoaponeurotic component. And I suppose the last thing that I'd like to speak on the role of ultrasound relative to MRI is we can do this dynamic evaluation, and that's the beauty of ultrasound.
Before you I'll jump in before we go through the dynamic aspect, just to come back and clarify. So the myotendinous aspect of that injury is more the superficial. Is that correct? Yeah, and myopneurotic is more the deeper version. Before we talk to dynamic, I might skip forward and just, I know I've seen you present a little bit around some classification or some thoughts around, I guess, a theory of subclassification of T junction injuries. Can you tell us a little bit about that? Is that an extension from what you're talking around there, or is it more than we can, more than you bring into the picture?
Yeah, this is not stuff that I've published. This is just what I have seen in clinical over and over time. It's like image recognition. And my take on T junctions on ultrasound is there seems to be 5 sub-classifications of T junctions that we actually see. And I have defined these from 1 to 5, 1 being the best outcome and 5 being the worst outcome. So to talk you through it, type 1 is, if you can imagine, just the T junction itself. And the horizontal component represents the myotendinous component. The vertical component represents the myoponeurotic component. Type 1 is where there is a defect to the myoponeurotic component only. And there's no defect to the myotendinous component. It's stable. On dynamic evaluation, there is no separation of the long and short heads. And there seems to be no defect within the myofascial tissue at the long head and the short head. So it's type 1. Type 2 is where we have a defect to the myotendinous component. Okay, so we have a defect to the myotendinous component itself, and there is no defect to the myoponeurotic component. There's no defect within the fascial tissue to the long and short head. And on dynamic evaluation itself, what we see is that there is no separation of both heads. Type 3 then is where we have a defect to the myotendinous component, the myoponeurotic component, and there always seems to be a defect within either the short or long head, so a myofascial defect itself. On dynamic evaluation itself, there is no separation of both heads of the biceps femoris. So I classify these as stable type T junctions. Type 2 and 3 are what I see, and maybe 4 are what I see as the most common types in my clinical experience. Type 4 is where there is a defect to the myotendinous component, myoponeurotic component. There seems to be a defect either within the short or long head or both, but we also have this associated intermuscular hematoma. So it's a more severe type of an injury. So now we present with an intermuscular hematoma. And for me, I think that's quite important to report that on images because we want to maybe say if that report goes back to a sports doc, a consultant sports doc, they might take it that they might do an aspiration. And they might get very little fluid out, but essentially they might just want both heads to adhere to one another somewhat better. And on dynamic evaluation for the type 4s, there is no separation of the long and short heads. Type 5 is your most severe type of T junction injury. And this is where there is a defect to the myotendinous component. There's a defect to the myoponeurotic component. There's a defect either within the long and short head myofascial tissue. You will have a large intramuscular hematoma. And on dynamic evaluation, you will have separation of the long and short heads. So this is where both heads don't adhere to one another. And in the acute phase, I often would report that a surgical opinion is advised in this case. So thankfully, we do come across them. They're not extremely frequent. It's not a case of for every T junction that I come in that there is separation of the long and short heads, but type 2, 3, and 4 are the most common ones that I would see clinically.
Okay, very interesting. I'm pretty sure. I'm very confident a lot of people will find that really quite interesting, an interesting take in. We were going to, around the dynamic ultrasound, I guess, based on what you've just said there, and we'll talk through what dynamic ultrasound is and what we do in a moment, only to the stage 5 was one that would really show on dynamic ultrasound true separation. Is that correct?
Yes. Yeah.
Yep.
Yeah. Your type 5 is when you do that restricted knee flexor contraction, you'll get separation of the long and short head. And it is quite difficult to do an ultrasound because, the separation, it's not a case of they just separate vastly on ultrasound. It's just with that contraction, you'll just see them moving away and both heads don't adhere to one another.
Yep. Okay, so yeah, fill us in. You have there, I guess, but yeah, fill us in on the aspects of dynamic ultrasound, when and why, and a little bit of the how.
Yeah, so it always anytime there is, as part of my assessment of a hamstring, regardless of its query T junction or proximal or mid belly intramuscular tendon, I'll always assess the T junction. I just always like to assess the T junction. My take is if you don't scan it and don't report on it, did you actually look at it at the scan time period itself? So at the very beginning, I always assess the T junction. And I'll do my static images, and then we'll do our dynamic evaluation. It's pretty straightforward. I swap over my scan with my right hand, but when I'm doing a dynamic evaluation, I place the ultrasound transducer into my left hand. The patient is lying somewhat prone on the bed in a comfortable position, and I place my right hand under calf, and I do a resisted isometric knee flexor contraction while my ultrasound transducer is in cross section at the T junction, or if at the defect of the T junction itself. And very, very carefully, I just see if there's any separation of the long and short heads. And you will see it. You have to really zone in on that T junction at that defect itself. And if you do see the long head essentially moving the opposite direction to the short head on live real-time ultrasound imaging, for me that's an unstable T junction itself, and that patient maybe should be considered for maybe a surgical opinion where they're referred to a surgeon to see are they going to go in and maybe stitch that area. But my take on type 1, 2, 3, and 4 where there's defects, what I have seen in the past is a lot of these should be managed conservatively with the clinician. They will take time. That's the tough part. But there seems to be reduced re-injury rates with these. There's nothing more complex than scanning a T junction where there's sutures in it and you get a re-injury. It's extremely difficult to scan. It's extremely difficult to assess all those connective tissue components in great detail. The sutures themselves give an artifact. It's quite difficult to assess everything in detail, to assess the finer details on the types of scar tissue, myofascial defects, if there's inflammation within the belly of the muscle, and to do that dynamic evaluation as well.
Okay, so I'll reference people to listen to Ernest Schilder's podcast that we chatted around some surgical decision making when it comes to these injuries, and in Fergal's podcast we probably chatted around the use of dynamic ultrasound as, I guess, a monitoring tool throughout a rehabilitation process to ensure that you're not getting the disassociation between the long and short head. And I'm assuming that's mainly for our level stage. Are you calling it stage 5? What stages? 5 stages?
Yeah, so it's a classification system or a subtype. So subtype 5 is where it's an unstable T junction.
Perfect. So as long as we've got our communication right, it's a subtype 5, unstable. Now I'm going to throw something at you because I know this is not published yet, and you're still working through things. But I guess you mentioned subtypes 1 to 4 would be more conservatively managed, like most hamstrings would be, and in most instances, a primary T junction would be. Have you got any inclination for us when you're talking timeframes? I guess maybe not for all different 4, but let's say maybe the number, subtype 4 versus subtype 1 or 2. Is that where you're seeing the spectrum being from maybe 6 to 8 weeks to 3 to 4?
Yeah, T junctions need time, and ballpark figures are anywhere greater than 6 to 8 weeks, 8 weeks essentially for a T junction. But they are complex, and there's always case studies that really make this answer quite difficult. What I see initially is for subtype 1s, obviously they'll heal up much quicker than maybe subtype 4 where there's an intramuscular hematoma. Interestingly, what I see on imaging is even though the myotendinous component, which is a denser, a worse prognosis because of all the collagen and the fibrous nature of that tissue itself, what I see is those types of defects actually heal much quicker than defects at the myoponeurotic component. However, if we were to return an athlete out onto the field where there was a defect within the myotendinous component, what I'm seeing is these athletes are the type of athletes to maybe sustain a re-injury much quicker than athletes who have a defect to the myoponeurotic component. So the defects at the myoponeurotic component are the better prognosis, but on imaging they nearly take longer to heal up. And the defects at the myotendinous component are worse prognosis, but they take much quicker to essentially knit back together. Everybody's biologically different. I have been involved in cases where the T junction has taken, as I said, 8 weeks. Some have taken up to about 12, 13 weeks, right down to where we have no structural defect. Most recently, we had a athlete who had a defect who had complete resolution after 6 weeks. So I think it's not just there's many factors. I think the biological nature of the person's response to healing and the type of rehabilitation prescribed is quite important, and they all play a part. But sometimes we've had 1 or 2 cases where there's been an unstable T junction, and the athlete has opted not to go for a surgical intervention, and they're the ones that take anywhere up to around 14, 15, 16 weeks.
Okay, yeah, some good insights. Look, there is still, you mentioned the biological healing and different. It's funny, having worked in professional sport in Australia, I'll come across different physios who will treat it just as a normal hamstring and they'll do completely fine a lot of the time. And then there'll be other ones where you would be conservative and try to do all the right things, and then they'll come unstuck. So I think there's obviously still a lot to sort of work through. And a good one of my mentors would say, 10 years ago, everyone was all worried about the intramuscular hamstring tendon and talking surgery and everything there. And then gradually over time, it's just come back, well, it's not even that much of a bigger difference to a normal hamstring rehab. And obviously now, which we're part of it, we're trying to get good information out there around the T junction. It's purely just to try to information share and not to sort of overdo it. But I guess what you're suggesting there is, clearly some great utilisation of ultrasound. That even though we're maybe being able to bring down some subtypes, it's probably not necessarily guiding us on shorter to longer timeframes from what you're saying. And then obviously we won't talk through, I guess, the unstable T junction and using a monitoring tool to guide you through rehab there. But you've just referenced, I guess, for the tendinous and myoponeurotic injuries, looking at healing on ultrasound, so quotation mark healing. I assume you're still using this throughout the rehab process to get a guide and maybe communicate that with your rehab coach and to provide information on readiness.
Yeah. Serial ultrasound sequential ultrasound is a fantastic tool to be used as an adjunct to that rehabilitation coach or the clinician. There's many image characteristics that we use to assess, particularly if you're just speaking about the T junction. in a nutshell, my whole take on it is unless there's all structural defects are absent, the athlete is at a higher risk of re-injury. And I've often had clinicians in the past say to me, well, there's always going to be structural defects post-injury, but or there's always going to be particular things shown up on imaging, but my take is the acute on non-acute stuff that we see. So the stuff like defects, edema, hyperemia response, inflammation within the tissue is much different to types of, let's say, chronic scar tissue. So the certain image characteristics, such as myofascial defects within the myotendinous component, defects within the myoaponeurotic component, they're much different to a scar tissue like a thickened intramuscular tendon. But yeah, serial ultrasound, I feel, should be used as an adjunct, definitely, throughout the rehabilitation period. It's essentially another set of eyes. Some of the best sports players in Ireland would often be referred into our clinic in Limerick just to monitor the rehabilitation period. And it's not a case of they're in every single day. It might be depending on the severity or the extent of the injury itself, but it might be every week or every 2 weeks, depending on, I suppose, competition coming up and, as I said, the severity of the injury. So, at T junctions, we're always assessing to see, is there a defect at the myoaponeurotic component, and you can see that come down between each visit. And there's times where we see that it hasn't come down, and if it hasn't come down, then that my role there is to relay it back to the rehabilitation physiotherapist, sports doc, therapist, coach to say, listen, the defect hasn't reduced in size, it's pretty much the same, and it's up to them maybe to recalibrate the type of rehabilitation, to maybe prescribe a new rehabilitation exercise to see, can they speed things up. And of course, yes, we have seen where things have gone wrong, where they might have pushed it maybe slightly too hard, and where we see that the defect actually increases. So we've come across that as well. So the key features that I look on at the T junction, serial ultrasound features, are myotendinous defects, myoponeurotic defects. If there is still any gapping, has that stopped now? We look at myofascial defect. I think it's really small, but we really have to try to make sure that we're now structurally intact. We don't want to see that edema within the muscle. According to your BAMIC, would be grade 0B. You can see quite well on ultrasound. It looks like just this. We use the term focal echogenic area, but it's just like a cloud, a focal cloud, white area within the muscle itself. Popping on a function called color Doppler. The muscle itself will be avascular, but if it's healing muscle, inflammatory muscle, it might light up. It might give us that Christmas tree kind of image on ultrasound itself. For me, that's a marker that the athlete on ultrasound shouldn't be sanctioned fit to return to play. We can look at the types of scar tissue. Yes, you can see it probably better on MRI, the types of scar tissue, mature versus non-mature scar tissue types. Mature scar tissue on ultrasound essentially looks, we use the term hypoechoic, but it's kind of grey, it's dark, whereas mature scar tissue is more echogenic, it's brighter, it's whiter, it's echogenic. So we look at scar tissue, we look at defects, we look at inflammatory signs themselves. So there's some of the things that I would look at throughout the rehabilitation period of an athlete, and they're markers that I would look at. And it's somewhat different than if you go into the belly of a biceps. Of course, your more severe type injuries are involving the central intramuscular tendon itself. So the key thing for me is we just want to make sure that there's no gap within the intramuscular tendon. And then when we're assessing around that area, we're going back to what I've alluded to in the past. We want to see that the fascicle planes are now back, that there's no edema within the muscle, and there's no hyperemia response. Because I have seen cases where you get that echogenic or cloudy like area within the belly of the muscle, but in particular if it hangs in around the intramuscular tendon, for me that's a red flag, and that player should be maybe pulled out of full competitive action for a couple of days, or 7 days, particularly when it hangs in around that intramuscular tendon, because I have plenty of cases where we've seen that edema, inflammation hanging in around the intramuscular tendon. The athlete continues competitive action, maybe goes out and plays a game, and straight away pulls up with that sharp, sudden pain, or some cases that pop, and it's manifested from a 0B into a 2C. So it is difficult. It's particularly in elite level sport. If you can rotate your squad a small bit more when you see something like this and get that player out and give him a rest for a couple of days, you won't be looking at something like a 2C, which can take anywhere between 4-6 weeks maybe.
Yep. Okay, so I know, as I mentioned, it's going to many will find it interesting, and I guess what you're saying, the old adage of treat the man or woman and not the scan, maybe doesn't apply or ring as true for a T Junction injury in your world, to use that space. So it's certainly up to the clinician to sort of be guided by, I guess, the information they can get to make informed decisions. So, mate, I think you're doing some really interesting work. Looking forward to what's coming next for you. Is there anything that we haven't covered that you sort of wanted to get out there or mention that we haven't as yet?
Not necessarily. I just think on our side of the world, ultrasound is somewhat underutilized, and but I do feel like some of the best sonographers in the world are based in Australia, Canada. I love the work of Daniel Walkie and all those guys, and we have Carlos Pedre up around here. But at any stage, if you do on MRI see a B injury and there's a clinical suspicion that there's essentially tendinous involvement, my take would be either get an ultrasound opinion on it, because you can see these structures quite well now, particularly with the new ultrasound application systems. They're absolutely fantastic. Or else maybe get your images reread, because we do see a lot of the time, particularly in our clinic, 50% of our hamstrings would be second opinions, and what's reported on the MRI might not necessarily always be what we see on ultrasound. And I do feel that makes a big difference for the likes of yourself, for clinicians, and for the athlete themselves.
Beautiful, mate. Now, we will get a couple of the reference notes, both your papers there that we had mentioned, architecture, and some of the work, the case series around the T Junction, in our show notes. And yeah, look, I'm sure if people want to reach out and have a few questions, would you be willing to take that? LinkedIn's probably the best method to approach.
Yeah, LinkedIn's fantastic. Yeah, so yeah, more than happy to take any questions.
For those going a little bit further, we do have a masterclass planned, filmed with Carles Pedret down in Spain. So that will take things to another level from here. So looking forward to that. But Kev, great to have you on board, mate. Really appreciate your time, and thank you.
Thanks, Nick.